Hello, my name is Abigail Baim-Lance, and I'm pleased to be sharing in the context of COVID, older HIV positive individuals' telehealth experiences managing HIV and other comorbidities on behalf of our research team, with particular appreciation for the lead on this project, Rachel Schenkel, who's done a substantial amount of the analysis for this piece of work. Very happy to be presenting here. As those attending this conference know, I'm sure are well aware, individuals aging with HIV are accounting for an increasing portion of the population of individuals living with HIV in the United States. So over half of the HIV positive number of people in the US are 50 years or older, particularly with the advent of antiretroviral therapy. People are living and managing their conditions pretty well, but this has also led to, for this older population, heightened disease burden at an accelerated pace compared to the general population, which includes increased incidence of comorbidities, among other things, other conditions, increasing psychosocial challenges, and with that, an increasing complex care and treatment landscape that individuals need to manage and navigate. Access to multiple specialties, integrated care, hopefully, and issues around polypharmacy. So we've been interested in how all of this is managed using telehealth modalities. And with the context of COVID, with really the health system shifting to telehealth and using telehealth more explicitly and expanding it, we're interested in how the management of and care needs of our older HIV positive population happens under these conditions using telehealth. So we're asking in this project, what are the experiences of older HIV positive individuals managing chronic conditions during the pandemic, and in particular, what it has been like to access and use telehealth to manage health, including primary and specialty services, given that many people are having to manage comorbidities along with their HIV. So this is part of a larger study, larger pilot study that preceded the COVID pandemic, but during COVID, its focus has shifted to have more of a COVID healthcare experience angle, and particularly thinking about telehealth. So we conducted a survey using Qualtrics, which was verbally administered and recorded. And the survey was semi-structured, so used open and closed questions. 45 questions were asked, and we were able to complete that with 80 individuals. And it was administered in English and Spanish by phone and in person between July and November of 2020. And it was administered with individuals receiving care through an urban academic medical center in New York City, as well as at a federally qualified health center, either in an urban, but not as urban as New York City, smaller town context, or rural clinics in New York State. And we asked questions about health between March, when New York State pandemic pause began, and the time of the survey. The question types we asked are listed in the table. And in addition, we had been conducting provider interviews around topics related to HIV and aging and comorbidity management, and those kept going. And so we have 11 semi-structured provider interviews in all with administrators and providers, medical providers. And in terms of analysis, we transcribed and coded surveys and interviews and conducted statistical, thematic, and narrative analyses. So of the survey participants, the mean number of comorbidities in this sample of 80 individuals was 4.6, in addition to HIV. And in terms of, in the total, not speaking to breaking down by site, but overall, about half of the sample was male, half was female, with one transgender woman participating. The mean age was 60 years old, and you can see the distribution of participants by race and ethnicity. It was a little bit different by CU and HRH sites, but not terribly different. So we asked the question around technology access, how do you regard the importance of technology for telehealth? And at the rightmost column, I don't have any challenges with technology was reported by around 50% or half of the individuals participating, so the 80, with a smaller percentage at the CU site and a larger percentage at the HRH. The other half of the group, though, cascaded into different kinds of issues, from not having technology for telehealth to not feeling comfortable with the technology or not knowing how to work it, or having disabilities. So we wanted to dive into that and understand that a little bit more, and learned that the technology gap is present for, as we said, about 1 in 5 individuals, or 20% of the individuals that we spoke to. And for that group, they said things like, I don't even know how to use a VCR, I don't have a smartphone, and I don't know how to run it. So not really having the access to the devices or to internet, or stable internet. But in addition to a technology gap, there was also something that looked more like a telehealth gap. So either limited comfort with the technology, so having it, but not really feeling, quote, savvy, which was a term that was often used, or in addition, or not really having comfort with telehealth per se. And so, in this quotation that we've pulled out, what we have found interesting was that for individuals that had the technology, they did often use it in different kinds of ways. Like, for example, this individual describes it at length, having WhatsApp and describing how she uses it with her family to communicate on a frequent basis. But at the same time, she didn't have the telehealth app, and said, quote, I don't know what to do with it. So there really seems to be something distinguishing about the telehealth applications. And we also learned that we can't think of telehealth as a monolith, but actually it's a plural mode. So individuals surveyed pointed out that they might use and like the telehealth platform as an app for, say, appointment scheduling or seeing their results, but they didn't want to use it for their medical visit. And this one Spanish-speaking Latina woman describes how that distinction. We also learned that we might think about telehealth as access to the video application, but in many cases among this group, they actually received their telehealth by phone, even when it began as a video visit. So this default to phone was a pretty common thing when the video didn't work. Providers not hearing patients, patients not hearing providers. The last part of this quotation says, and when she responded, we couldn't hear each other. And then she called me, and that's how we were doing it. And that was a kind of a common story that we heard. In terms of the gap, we learned about the importance of the setup support and the outreach that the facilities were doing to enable telehealth, as well as where respondents said they didn't have that support and they needed it if telehealth was going to be available to them. Several individuals in the sample also described not really knowing about telehealth options or the platforms available. So then we asked, of those individuals who used telehealth for a visit, how did it compare to in-person visits? And about 70% overall, with a higher percentage at the CU site, said that it was worse, with the other 25% or 20%, 30% either saying for some it was better, about 10% saying it better, and about 20% saying it was about the same. So we really wanted to dive into this quality issue and how quality was being defined and considered. So there was the kind of dimension that picks up on the access issues, where there were sort of glitches or delays or cancellations or strained connection, making strange connections. And so there wasn't sort of the smooth encounter related issues. And then there was another category that is a pretty large and important one, which is about the importance of what happens in the physical interaction, what people think about in terms of what they value in that when they see their provider, the importance of their own communication style. Like, for example, this quotation at the end talks about talking with hands and how important that is. You can be more yourself, and that can't happen over the tele option. Others talked about how being in a clinical space was a memory jogger for them. It let them remember things or be more expansive in their questions. And they thought their providers had more flexibility around their time, the time they took with them. So there was something a little more open about an in-person visit compared to a more targeted or focused telehealth encounter. Another participant who also favored the in-person talked about feeling that he had more confidence and more comfort by speaking to his provider in person, and said it is also very comforting if you're dealing with something you're not sure about, and to have that, it's a different type of attention that's given in person than it is over the phone or video. So we thought those kinds of sentiments are important to think about. There was also several instances of potentially substandard care that was delivered through telehealth, and it's hard to know whether we can connect that up to the modality compared to in-person. But for example, one participant actually had a referral for physical therapy put in for the wrong side of his body. And he at least thought that that was connected to not being able to see him in person. This quotation we've included around substandard care is a kind of concern a provider raises, feeling that telehealth may be a suboptimal approach. So providers are thinking about that as well. There were a lot of individuals responding about how telehealth was good given the COVID relativity or COVID situation. I would love to see her in person. It's much better, but since the COVID-19, I don't like to take chances because I'm an HIV patient. And so in the context of HIV, they really felt that telehealth was an important avenue for them. And finally, of the 30% or so who said that telehealth was either as good or better, they talked about those individuals talked about the importance of saving the trip, their confidence in their own self-care behavior and routines, and that another point that was raised was that they felt they already had established relationships with their providers, and it was easier to transition to a telehealth format. So in sum, significant multi-level technology and telehealth gaps existed for some older HIV positive individuals to manage care through telehealth options that we have to think about. Patients also described the importance of the physical dimensions of in-person care, though convenience to care with telehealth was also appreciated. While COVID presents a unique reality, moving forward with telehealth requires considering when, how, and under what circumstances it works best to optimize rather than undermine patient-centered care. And developing strategies to enable equitable access may also be important. And here is our study team. And I look forward to the conversation Q&A portion. Thanks so much for listening.